Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good evening, May 11th. Thank you for joining us for our COVID-19 update. As of this evening, Worldometer reports 1.38 million cases and 81,000 deaths in the United States alone, and approximately 4 million cases and 286,000 deaths worldwide. In global updates, data from the Financial Times shows that the U.S. has averaged 5,000 daily coronavirus deaths over the past week and continues to account for 1/3 of global daily deaths. Brazil has overtaken the UK to have the second highest average daily death rate. In Europe, Russia has overtaken Italy and is now reporting the fourth highest number of coronavirus cases behind the United States, Spain, and the United Kingdom. Russia has consistently been reporting record daily increases in new cases with more than 11,000 new cases in the past day alone. In the United States, the FDA has granted the first emergency use authorization for a COVID-19 antigen test, a new type of coronavirus test that could diagnose current infection within 15 minutes. These tests are different from the PCR and antibody tests that are currently being used because they detect viral surface proteins from nasal swabs rather than viral genetic material or human antibodies. Because they're cheaper and easier to manufacture, distribute, and use, antigen tests are valuable screening tools and are often used in clinics to test for common infections like strep throat. However, the test has a lower sensitivity than PCR tests, meaning a higher chance of producing a false negative. So the FDA has warned that all negative coronavirus antigen tests should be confirmed with a PCR test, which is a common protocol for rapid antigen testing. This does not excite me very much, Mike. I was excited actually when I heard there was an antigen test because I thought that was going to be very helpful, but there's several issues here. Number one, what we're trying to do now is rule people out, not rule people in. And if we just automatically reflex to a PCR test, we've just wasted time.
Yep. And you're not gonna make any legitimate decisions based on the results of this test. So you can't. It's not like you can let someone into an office building because they've got a negative antigen test. The sensitivity is just not going to be high enough.
Right. I mean, you could, if it's positive, you could tell someone. I mean, so in theory, let's say you have an office, medical office, and you're using this to screen people to know if they can have surgery or something. Well, if it's positive, they can't. But if it's negative, it doesn't really help you. You still got to do the PCR test. And it's also, I need to look at this test a little more before I understand. It looks like it's probably a synchronous test, meaning you can run one every 15 minutes, which is not that many. And even if you can run more, again, the issue is that it's not sensitive enough to rule it out. And that's what we want to do right now is to rule this out. Tomorrow, we're going to be releasing a full podcast on pooled testing, which we're really excited about and we think is the actual solution to this testing problem that we have in the United States.
You know what I think this test is useful for? An antigen test is useful if you have a specific treatment that you can offer somebody and you want to know if it makes sense to go ahead and give them that treatment. We don't have a treatment. So there's really no benefit because you're not ruling out disease. That's where the true question is right now clinically.
Right. So in his daily briefing this morning, Governor Cuomo announced that 3 upstate regions in New York may begin to reopen this weekend by allowing certain low-risk business and activities to resume operations. These regions have met all 7 of the criteria that were laid out by the governor last week, including maintaining a sustained decline in new coronavirus cases, as well as increasing testing, contact tracing, and hospital capacity. The governor also announced that this morning New York recorded its lowest number of new coronavirus hospitalizations since before the state's lockdown began, as well as the lowest daily death toll since the end of March. I really applaud Governor Cuomo. He laid out how they're going to open up, and he is waiting till these regions are doing that. So that it's really great to see. Elsewhere in New York, health officials are reviewing 85 known cases of a mysterious syndrome in children that may be linked to coronavirus. The illness, known as pediatric multisystem inflammatory syndrome, looks kind of like Kawasaki disease. So if you're a physician and you've seen Kawasaki disease, you know what that is. It's an inflammatory disease of the heart and blood vessels. 3 of the children in New York have died from the illness, with 2 more deaths under investigation. Similar cases have also been reported along the East Coast, as well as in European countries that have experienced severe coronavirus outbreaks. I wanted to stop just for a second and just say this has been all over the news, and it is horrible anytime a child dies, but I think it's being reported more sensational than it probably actually is. Deaths in children are horrific. It's the worst thing as a physician, as a parent, as anyone to see this. But we've got a big population. So when we start talking about 2 deaths or 85 cases, it's great to report and to note that and to think about it. But I don't think this changes a whole lot of what we do. Just to run some numbers for you, some of these may be slightly off because I'm doing them off the top of my head, but in New York City, there's between 500,000 and 1 million kids under 5 years old. So in Kawasaki's disease, it's kind of a rare disease, but we do see it. It happens in kids under 5. And in general, we think the prevalence is about 25 cases per year per 100,000 population. So if you have, just to make the math a little easier, 800,000 kids under 5 in New York, then 25 out of 100, that means 200 cases of Kawasaki's disease in a year. Now, if we say that, and we're talking about 85 known cases of this mysterious syndrome, so I don't find this highly unusual. This is an inflammatory disease. Kawasaki disease is an inflammatory disease. I would expect with the number of people, the prevalence in New York City of just COVID-19 in general, that we're going to start seeing some complications like this. So it's still dramatically less risky for kids than adults. It's something to watch out for. But I don't think the risk in kids has not all of a sudden dramatically increased. It's just that now we have enough children that we're starting to see some complications from it.
Yeah, and we're starting to see similar sorts of reports about, for example, Guillain-Barré disease, which is an autoimmune disease that's often post-viral in nature. So you get a virus, then your body has sort of this autoimmune reaction attacking itself, in this case, the spinal cord. So it's not uncommon for viruses, any virus, to have these sorts of strange, unusual outcomes or side effects, like, for example, this thing that you're talking about in pediatrics. So it's a good point that you make. I think it's important, Matt, just to remind the clinicians out there that they need to keep their eyes open. They need to be thinking about, these sort of rare diseases, because there could be a potential small uptick in them with this virus making the rounds. I think that's probably about the extent of it. Otherwise, I agree with you. I do believe it's a touch fear-mongery.
Yeah, and we don't want to make light of it. It's important to note, but what I'll say is I have 4 children, and my concern for them after reading this honestly has not really changed or gone up. This is a rare illness, and I know there are plenty of rare illnesses out there.
Which is a good segue into our literature. The first article that we're talking about today, Matt, is out of the JAMA Pediatrics, was published on May 11th, 2020. Characteristics and Outcomes of Children with Coronavirus Disease 2019, Infection Admitted to U.S. and Canadian Pediatric Intensive Care Units. So this is a very large study. It's the most comprehensive analysis that we have yet of COVID-19 infection in children. And it was a cross-sectional study that reviewed 48 pediatric coronavirus cases, including 2 deaths from 40 different PICUs. So they had to go to 40 PICUs in order to get 48 pediatric coronavirus cases that were admitted to the PICU. So that tells you that the prevalence is very low for sick children with this disease. The researchers found that severe coronavirus illness in children is significant but far less common than the adult population. a finding that is consistent with current anecdotal evidence. More than 80% of the patients in the study had significant pre-existing comorbidities. Basically, more than half of these kids had developmental delay. They had cerebral palsy. They had lifelong disease, basically. Some of them had tracheostomy tubes or feeding tubes. And it really reinforces that otherwise healthy children are extremely low risk. But at the same time, it's a good reminder that not healthy children, children with chronic disease, maybe kids that can't speak or can't walk, are at higher risk. So we can't treat them like they're as low risk as their peers, which is, I think, a good reminder. And I think plays to the fact that we should probably be protecting those people in the population to some degree, just like we are trying to protect the elderly.
Yeah, for sure. And again, just to put this in context, you made a great point. So they looked at 40 different PICUs. So PICUs draw usually from a large population. To have a pediatric ICU, it's usually a large population you're drawing from. And in 40 PICUs, it's that only 20% of the patients didn't have significant pre-existing comorbidities. So less than 10 patients. So less than 10 kids that didn't have pre-existing illnesses out of over 40 PICUs that they surveyed. So exceedingly rare in healthy children. Other children, we're always going to be protecting them if they have these significant illnesses anyway. We're always trying to keep them safe. So nothing really changes here. We just want to be extra careful with these kids, just like we do with the elderly or other people that have pre-existing conditions.
Next study is an observational study of hydroxychloroquine in hospitalized patients with COVID-19, published on May 7th in New England Journal of Medicine. This was an observational study that was conducted in New York City. There were 1,446 patients. It was a consecutive study, and we've talked about that before on the podcast, meaning that everyone who got admitted was enrolled into the study. Of those 1,400 or so patients, 59% of them got hydroxychloroquine. The rest did not. When you compare the two groups for intubation and death, there was no significant difference between the two groups. Now, this is a little bit complicated because the two groups were different, and they even admit this in the study. The hydroxychloroquine group was a group of sicker patients, and this makes sense. If you're not randomizing patients, you're just doing an observational study, physicians are much more likely to give the medication, whether they know whether it works or not, to the sicker patients. So this is a little bit challenging. They tried to adjust for this in the study. They used something called a multivariable regression model with inverse probability weighting. I'm not going to go into that, but they used that to basically try to say, like, okay, these people are at higher risk, and therefore we expect them to have this amount of disease. So how did the hydroxychloroquine change things? Bottom line is, it doesn't look like there was a significant difference between the hydroxychloroquine group and the non-hydroxychloroquine group. This is consistent with what we've seen in most of the recent data on hydroxychloroquine, and I think just functions as another small nail to place in the coffin for the hydroxychloroquine camp, unfortunately.
Yeah, but just to beat this dead horse, is non-randomized, and whenever you see multivariable regression model with inverse probability weighting according to the propensity score, you want to say A for effort, but it still doesn't replace a randomized controlled trial.
Right. It gets a bit academic for sure. All right, last article I wanted to talk about. This one I'm excited about just because of the size of the data. So this was a press release about an article that was released online on May 7th. It's in preprint. It hasn't been peer reviewed yet. You can find it on MedRx. The name of the article is "Risk Factors for COVID-19 Death Revealed in World's Largest Analysis of Patient Records to Date." So the data is published from the NIH, so this is out of UK, and they looked at 17.4 million UK adults and their likelihood of dying from COVID-19. So the whole point of this study was basically to look at pre-existing condition and potential risk factors regarding your likelihood of death from COVID-19. And like I said, a ton of people, 17 million adults, over 5,700 deaths in the study group. Some interesting findings in this, Matt. So it found that Asians and Blacks had the worst outcomes. And this was independent of pre-existing conditions, suggesting there's a genetic predisposition to death or severity of illness from COVID. And that's something that, we had kind of teetered around previously in some of our data, but had always been assumed to be related to other pre-existing conditions. But because this data set was so large, they were able to extract out the pre-existing conditions and find found that just that genetic predisposition or that ethnicity was enough to suggest an increased risk. And that was about a 2 times increased risk for those 2 ethnicities, which is significant. When you look at the odds ratios, there's an excellent graph in this article where they actually graph all the odds ratios for pre-existing conditions, and you can see which ones have the greatest effect. And I'll try to post this on Instagram so people can take a look at it, and we'll put the link in the show notes so that people can go and take a look at the article themselves. But the greatest odds ratio, highest risk of death, was in the age group over 80. Not really mind-blowing stuff there. We knew that age was a giant pre-existing condition. The next highest group was age greater than 70. The next highest group was history of organ transplant and history of cancer. So from there, we can also see that there are multiple different pre-existing conditions that are associated with a 2 times increased risk of death from COVID. And those include obesity. If you're a male, so just being male increases your risk as opposed to being a female by, I don't know what else you would be, by 2 times. And then also immunosuppression increases it by 2 times. Kidney disease and respiratory disease all increase by 2x. So this to me is really important for risk stratification. As we start to open up, people have questions about what is my overall risk. And we as physicians have to be able to communicate with people what their likelihood of having a severe disease process from COVID is. And this is the beginnings of and a very quality amount of data to start to have that conversation with our patients. Like, okay, you've got this disease process, and you're 64 years old, so we can now estimate your odds ratio to be such and such.
Yeah.
So this is extremely helpful from that standpoint.
This is really interesting, the age thing too. We knew that people who were older were at higher risk, but I would not have predicted that just being over 70 would put you at higher risk than a history of organ transplant. That's pretty interesting. If you've had an organ transplant or you've had cancer, you're not as high risk as over 70. And I think that's important just to know. Like you said, as we open back up, we really got to be careful if you're older. Didn't you say there's
Absolutely.
something about smoking that decreased? Were you not going to mention that?
I wasn't really going to mention it just because I don't want to tell anybody to smoke, but it did look like there was a significant difference for people who are current smokers, just a very small decreased likelihood for death.
And when you say significant, you don't mean a big decrease. You're using that in a technical term, statistically significant. But it was a very statistically, which is probably a trick of the statistics in some way. You're probably not actually at decreased risk if you're a smoker. From this, I had
seen another article on Twitter suggesting the same thing. So there might actually be something to this. I haven't had a chance to dive into it too much, mostly because what's the point? I'm not going to tell anybody to smoke, even if it does decrease your risk of death from COVID by 0.2%. But maybe I should just dive into it and see if there's anything there. I mean, theoretically, there could be some effect, metabolically or on the molecular level in terms of, ACE2 expression, things like that. But I haven't had a chance to dive into that yet. So I didn't want to speak to it.
No, that's the nicotine argument. So I've heard that a few times. Yep. Right. Actually, I think some places they've stopped, because that data came out, they've stopped selling nicotine gum unless you had I don't know if you had a prescription or what, but they've limited the sales of that. So that certainly could be the case that nicotine is actually helpful in decreasing the risk. Either way.
Yeah, the problem with the nicotine argument though is that the data is mostly in smokers. So there's not a lot of data on nicotine use outside of smoking. Like when you really dive into the nicotine argument, it's almost all patients who are smokers. You can't find studies on people who just use gum for the most part.
Yeah. Well, regardless, Mike and I have started a farm where we are raising neutered llamas that smoke Marlboro Reds, because we're pretty sure the convalescent plasma from those the antibodies is going to. And if you don't get that joke, then you certainly need to start keeping up with the updates that are
right, especially the last one, because it was the most entertaining one yet.
Yeah. So. The actual one of the actual solutions, though, not neutered llamas who smoke, we're going to talk about tomorrow on the podcast, and that's pool testing. We've talked briefly, but we recorded a much more in-depth video going over all of the math and why we think this is a really great solution. So make sure that you do tune in for that, and we'll give you an update on our llama farm as well, probably. Thanks for listening.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.